Let's start. Let me check whether the streaming platform is correct or not so that I can start my session. Let me check my own YouTube link. Please wait for about a yes. Thanks a lot. Right. So today, this Farre series is mainly meant for people who are planning to write their theory examination part. So we all know that nowadays MBBS curriculum is mainly based on key points. Whenever you have some key points, whether you write it or not, people used to write pages and pages, but we don't take all those things into account. Whenever we go for any paper correction, invariably we will be looking into simple things, whether key points is there or not. When key points are there, it is there or not, even when you have not written 2 pages or 3 pages, you will be given full marks. So with respect to 5 marks and 10 marks and essay, we are planning in such a way that you need to write key points so that you will be getting full marks in your theory examination. Shall I start my session right now? Right. So the today topic, and you all know that neonatology, you have some separate questions, not only in your theory examination, but also in your entrance examination. But let us now concentrate on neonatology. As far as final year candidate is concerned, whenever you speak about neonatology, the first thing is neonatal resuscitation. What do you mean by neonatal resuscitation? Whenever any child doesn't cry immediately after birth, it means that the child may undergo hypoxic ischemic encephalopathy, as a result of which the child may have a permanent neurological sequelae. So the first question we are going to target on neonatal resuscitation, very, very important. Let's start now. Right. First, question number 1. Discuss the key steps and protocols involved in neonatal resuscitation according to the latest guidelines, including the following in your response. Initial assessment and preparation steps immediately following birth. Actions to ensure a patent airway and adequate ventilation, including ventilatory corrective steps. 3. When and how to initiate chest compressions and administer medications if necessary. 4. Criteria for discontinuing resuscitation efforts. So these are all the questions we are going to discuss right now. All right. Okay. But before proceeding to this topic, let me explain something about primary apnea and secondary apnea. What do you mean by primary apnea? Whenever any child is born, after birth it has to cry. When the child didn't cry after birth, it is presumed that the child has undergone hypoxia. The initial stage of hypoxia is characterized by primary apnea. What do you mean by primary apnea? Primary apnea is one in which, look at this, in which in primary apnea, when the child is undergoing the first stage of apnea or hypoxia, what will happen to the heart rate? The heart rate will be reduced. That is heart rate will be reduced. That is called bradycardia. But the blood pressure is usually maintained. So primary apnea is characterized by two things. Normal heart rate nahi hai, it is bradycardia along with the normotension. Whenever you give bag and mask ventilation, or whenever you give a tactile stimulation at this stage, I repeat, whenever you give tactile stimulation at this stage, the child will may or may not respond to it. So primary apnea is nothing but the initial stages of the apnea characterized by bradycardia, that is low heart rate and normotension. Whereas when you don't treat the child properly, the child will go for secondary apnea. What do you mean by secondary apnea? In secondary apnea, apart from bradycardia, the child will have hypotension. The child will have hypotension. The BP will always be reduced. So primary apnea is characterized by normotension and secondary apnea is characterized by hypotension. In secondary apnea, you need to start bag and mask ventilation. So before going to our topic on neonatal resuscitation, you need to know what is called primary apnea and what is called secondary apnea. Now let us go to the topic. So I think you are all clear with the primary and the secondary apnea. Right. Now let's see resuscitation of the newborn baby. As soon as the baby is born, the baby should cry immediately after birth. If the child doesn't cry immediately after birth, if the child doesn't cry immediately after birth, okay, if the child doesn't cry immediately after birth, the child is said to have undergone hypoxia. Whenever any child is born, what are all the assessment points that you need to know? Initial evaluation of the assessment. You need to concentrate only on three things. So, what are all the three things that you need to concentrate? Right? Whether the child is crying or not, whether the respiratory effort is present or not, and what about the tone of the baby. So whether it is a term baby or preterm baby, because resuscitation for term baby is different, resuscitation for preterm baby is different. Point number one. Second baby, whether the baby is crying or not. Crying means the child has established the breathing. Third point is tone. When the child is having birth asphyxia, tone will be decreased as a result of hypoxia leading to hypotonia. So these things should be seen in case of when the child is immediately born after birth. As soon as the child is born, what are all the initial steps of resuscitation? Very simple. So let us presume that you are in the you are in your labor ward, and one intern has conducted, or OGPG has conducted delivery. As soon as the child is born, what you are supposed to do? Point number one. So you need to get the child in a pre-warmed towel. Point number one, what you need to get the child in a pre-warmed towel. Why pre-warmed towel? Because when the towel is not warm, the child will lose its temperature by means of conduction. So bring the child in here. You need to get the child in a pre-warmed towel. Second point, you need to keep the baby under a radiant warmer. Again, you give some sort of heat. Third point, you need to put the baby in sniffing position. What do you mean by sniffing position? Sniffing position is nothing but keeping a roll of towel under the shoulder blade, so that your nose, your nasopharynx, and your trachea will be in a straight line, so that the air passage will be fine. 3. Fourth point, then what you need to do? You need to wipe the liquor present in it. You are not supposed to wipe the vernix gaseosa. So these are all the initial, this is called drying. So get the baby in a pre-warmed towel, keep the baby under a radiant warmer. Third, keeping the baby in sniffing position. Fourth one, dry the liquor and not the vernix gaseosa. So these are all the initial steps of resuscitation. So this is radiant warmer under which you need to keep the baby. Second one, what is this is called sniffing position. Very, very important. Examiners might be asking you what is called sniffing position. Keeping a roll of towel under the shoulder blade is called the sniffing position, so that your nose, your nasopharynx and trachea will be in a straight line. This is called sniffing position. Right. And then what about suctioning? Suctioning, usually another question they will be asking you, whether you will suck the no, because whenever the child comes out of the vagina, there will be plenty of liquor either in the amniotic fluid, either in the nose or in the mouth. You need to suck the secretions that is present in the mouth first, followed by secretions present in the nose. Why secretions in the mouth should be aspirated first? The answer is very, very simple. Whenever you start aspirating the nasal content, the breathing effort will be increased, as a result of which there are chances for the child to aspirate the contents that is present in the mouth. Compared to nose, the amount of liquor or amniotic fluid in the mouth will be more. As a result of it, there are chances for the child to aspirate the amniotic fluid content. That's why suctioning of the mouth followed by suctioning of the nose. So these are all the initial 5 steps of resuscitation. These are all the initial 5 steps of resuscitation. So I repeat, you get the baby in a pre-warmed towel, keep the baby under the radiant warmer, keep the baby under the in sniffing position, and then dry the baby, suctioning of mouth followed by suctioning of nose. How long you need to take for this initial steps of resuscitation? You need to take only 30 seconds for this initial steps for resuscitation, you cannot take more. All these steps should be completed within 30 seconds after birth. And one more question they will ask you, how long you will take to clamp the cord. Okay, now we are something following called a concept called delayed cord clamping. What? Delayed cord clamping. What is called delayed cord clamping? You clamp the cord 30 seconds to 60 seconds after birth. Why 30 seconds to 60 seconds after birth? By clamping the cord in a delayed manner, the some amount of blood that is present in the placenta from the maternal circulation will reach the fetus, will reach the newborn, as a result of which the tendency of the child to develop anemia in the newborn period or in the infantile period is less. So remember, delayed cord clamping is another important question in which you need to clamp the cord 30 seconds to 60 seconds after birth. Okay, right. So all these you are taking only 30 seconds. Initial steps of resuscitation, 6 points, 30 seconds. Now, at the end of 30 seconds, you need to see whether the child is crying or not. If the child is crying, well and good, you can aram sit and watch the child crying, because the because the breathing has been established, your mission has become accomplished. But if the child doesn't cry if the child doesn't cry even after your 30 seconds of initial steps of resuscitation, what you are supposed to do? You are supposed to do tactile stimulation. So what do you mean by tactile stimulation? Tactile stimulation means you need to gently rub the soles of the baby, gently rub the spine of the baby. This tactile stimulation will work when the child is present in primary apnea. What do you mean by primary apnea? Primary apnea is characterized by bradycardia and normotension. So during this stage, whenever you give tactile stimulation, the child will start crying. So this is the concept behind the tactile stimulation. How long you can take this tactile stimulation to work? Only another 30 seconds. So at the end of 1 minute, your initial steps of resuscitation, delayed cord clamping and tactile stimulation should be over. Why? Because at the end of 1 minute, if the child doesn't cry, you need to start positive pressure ventilation. What? If the child doesn't cry after 1 minute of birth, you need to start positive pressure ventilation, otherwise known as bag and mask ventilation. Right. Now let's see one by one point. So listen very carefully. This is a very important point on neonatal resuscitation. This can be an essay question. This can be your short notes. This can be also your often asked question in your Viva OC. Look at this. So the child is born. So you all think that you are in a place where a child is born. The child is born. As soon as the child is born, what are all the three things I told you to look into? Three things. One is whether the child is a term baby or preterm baby. Term baby resuscitation is somewhat different from preterm baby. Second, breathing or crying. Why? When the child breathing or crying means when the child starts breathing, you need not worry. Third one, tone of the baby. Why tone of the baby? Because whenever the child is in birth asphyxia, it will lead to hypotonia. So three things that should be seen immediately after this one, immediately after birth is these three things. Term or preterm, breathing or crying, tone is good or bad. When everything is good, just keep the baby under a warmer after clearing that I told you, initial steps of resuscitation. All those things can be done, and roll the baby in a pre-warmed towel, suck the nose, then suck the mouth, dry the liquor, then hand over the baby to the mother. Okay, so this is point number one. So what is point number two? But remember, when the child doesn't cry immediately after birth, birth, what you are need to do? Again, initial steps of resuscitation along with the tactile stimulation. I repeat, initial steps of resuscitation along with the tactile stimulation. Your assessment and initial steps of resuscitation will take 30 seconds, and your tactile stimulation will take another 30 seconds. So by the end of 1 minute, you need to decide whether the child is going to require positive pressure ventilation or not. And how do you know that the child is going to require positive pressure ventilation? Very, very simple. As we discussed already, whenever the child is in apnea, the initial manifestation is bradycardia. So, heart rate less than 100 per minute is an indirect clue that the child has been suffering from hypoxia or apnea. I repeat, heart rate less than 100 per minute. So when the heart rate is less than 100 per minute, I repeat, when the heart bradycardia means heart rate less than 100 per minute, or if the child is not breathing at all, apnea, or breathing in poor respiratory effort, that is called gasping. When these things are present at the end of 1 minute after birth, you need to start positive pressure ventilation. What do you mean by positive pressure ventilation? It is nothing but your bag and mask ventilation. Okay. So what you need to do, with the help of a ambu bag and a mask, you need to give positive pressure ventilation. So how many, because the child is not breathing on its own. So how many times you need to give this positive pressure ventilation? Okay, a minimum of 30 to 40, a minimum of 30 to 40 ventilations per minute, a minimum of 30 to 40, you need to press the ambu bag and it will release on its own. So this is called positive pressure ventilation with the help of a bag and mask. So now you have started giving positive pressure ventilation. You are at the end of 1 minute. Then what you are going to assess? Can you tell me? Then what you are going to assess? Then what you are going to assess? You are going to assess whether the heart rate is increasing or not. If the heart rate is increasing, you are on the right track. What you are supposed to do? If heart rate is more than 100 per minute, you can discontinue positive pressure ventilation. When the heart rate is between 60 to 100 and it is not increasing, means there are some problems with respect to your way of giving bag and mask ventilation. So what does it mean? When the heart rate is not increasing despite giving bag and mask ventilation, it means that you need to do some ventilation correction steps. What is that? Ventilation correction steps. That question was asked. What is this ventilation correction steps? It is called Mr. SOPA. What is called Mr. SOPA? M stands for properly applying the mask. So you would have seen that the mask might be leaking from the nose end or mouth end. So proper snugly fitting the mask covering the nose and mouth. Second, at times you need to reposition the neck. Okay, reposition the neck. The neck might not be in a sniffing position, so that you need to keep the roll of towel under the shoulder plate. This is called R, reposition the neck. Third, yes, what is yes? Yes stands for suctioning. It might be due to the amount, despite your initial suction, still there might be some amount of secretions that is present in the mouth. So suctioning of the mouth. And then O, what is that? You can't do a bag and mask ventilation in a open mouth. You need to close the, you need to open the mouth and do the bag and mask ventilation. So you need to open the mouth. O stands for open the mouth. And then P, so what does it mean? P, you need to give adequate pressure. You need to give adequate pressure. It doesn't mean that, oh, it is a small baby, I need to handle the baby gently, so that I should not press the ambu bag in a adequate way. Though it is not so. You need to give a proper pressure over the ambu bag. So P stands for pressure. And then finally, so despite all these ventilation correction steps, still if the child is not showing any form of increase in heart rate, means then you need to go for alternate airway. What is called alternate airway? Instead of bag and mask, you need to put intubation. You need to intubate the child, endotracheal intubation, provided you know the technique of endotracheal intubation. If you don't know the technique of endotracheal intubation, blindly you can do LMA. What is called LMA? Laryngeal mask airway. I repeat, blindly you can do you can insert a tube called a laryngeal mask airway instead of endotracheal tube. Endotracheal tube, when you know the technique, you need to put the endotracheal tube, it will go and stay just above the carina. And you connect the ambu bag to the endotracheal tube. So this is called endotracheal intubation. But it is not that easy to put endotracheal tube at the time of emergency. Some of you, whether you may be new to the intubation, but what you need to do at that time, you need to do laryngeal mask airway. What is called laryngeal mask airway? I will show you. So you need to keep one mask called LMA, laryngeal mask airway. Blindly you need to insert into the oral cavity the end of the, the end of the laryngeal mask airway will contain a mask that will go and snugly fit over the laryngeal inlet, so that the other end you can connect to bag, and your other end can be connected to ambu bag, so that you can do a bag and tube ventilation, so that you can do a bag and tube ventilation. Okay, right? So let me say, what are ventilation correction steps? What are ventilatory correction steps? Another short notes or another subunit in that essay question. Mr. Sopa, M stands for. So when you will think in terms of ventilation correction steps, despite doing bag and mask ventilation, there is no increase in the heart rate. When the heart rate between 60 to 100 and not increasing means you are not doing when you are not doing bag and mask ventilation properly, then you need to give ventilation correction steps. It stands for 6 points. M stands for mask, properly position the mask. Okay, R stands for reposition the neck. S stands for suctioning of the mouth again. O stands for open the mouth adequately. P stands for adequate pressure. Despite any of these steps, if the child still not showing increase in the heart rate, A for alternate. Alternate means either you need to put an endotracheal intubation or you can put a laryngeal mask airway. Right. So this is how you need to give your ventilation. Okay, this is how you need to give your ventilation. So look here, when the heart rate, so positive pressure ventilation you are giving, still you need to, then again and again you need to ask whether heart rate is increasing or decreasing. When the heart rate is increasing, always you are in a place, you are in a safe place. What you have been doing is correct. When the heart rate is not giving, not increasing, despite positive pressure ventilation, take ventilation correction steps. What are ventilation correction steps? As I told you already, Mr. Sopa. Right. And then, so again, after you are taking another 30 seconds to do all these ventilation correction steps. And the end of 30 seconds after ventilation correction steps with the bag and mask ventilation, or bag and tube ventilation, or bag and laryngeal mask ventilation, again look at the heart rate. If the heart rate is 60 to 100 and increasing means continue bag and mask or bag and tube or bag and laryngeal mask airway ventilation. Heart rate is more than 100, there is no need for any resuscitation. 60 to 100 increasing means you need to continue ventilation till the heart rate becomes more than 100. Okay, but if the heart rate is less than 60 per minute, what you need to do? I repeat, if the heart rate is less than 60 per minute, what you need to do? Right now, your heart loses its capacity to pump on its own. That's why you need to start your cardiac massage. That's why you need to start your cardiac massage. So when heart rate is less than 60 per minute, you need to intubate the child. Chest compression you need to start. What do you mean by chest compression, my dear boys and girls? Either you can use 2 fingers or you can use 2 thumbs over the lower end of the sternum. Okay, over the lower end of the sternum, but you need to give a adequate pressure. What do you mean by adequate pressure? Adequate pressure means it produces a force so that it goes more than 2/3 of the transverse diameter of the thorax. That is called adequate chest compression. Again, one more question they will ask you, whether it is 2 finger technique or 2 thumb technique. 2 finger technique is this one. This might not be adequate. So you need to use 2 thumb technique. Now you can ask me, sir, chest compression one person is doing, bag and mask ventilation or bag and tube ventilation one person is doing. What is the ratio of this? Very, very simple. So you need to use 3:1 ratio. What do you mean by 3:1 ratio? 3 chest compression, 1 ventilation. So what we do? 1, 2, 3 chest compression, mask. 1, 2, 3 mask. 1, 2, 3 mask. So this is called 3:1 ventilation. So this is called cardiopulmonary resuscitation in 3:1 ratio. How many events per minute? So I repeat, 3:1. 3 chest compression and 1 ventilation. 3 chest compression and 1 ventilation. And totally you need to do 120 events per minute. 120 events means 90 chest compressions and 30 ventilation. 90 chest compression and 30 ventilation. This is called cardiopulmonary resuscitation. Okay, at the end of 1 minute of chest compression and bag and tube ventilation, if the heart rate is still less than 60 per minute, you need to go for inotropes. What is the inotrope? The inotrope is nothing but your adrenaline. 1 second. Inotrope is nothing but your adrenaline. So what is the available strength of adrenaline? Can anyone mention? Available strength of adrenaline in your what? Available strength is 1 in 1000. You can't use it directly. So 1 ml contain 1 in 1000. Okay, then you need to take 1 ml, you add 9 ml of normal saline. So it becomes 1 in 10,000. So that it becomes 1 in 10,000 adrenaline. In this 1 in 10,000 adrenaline, you need to take 0.1 ml per kg to 0.3 ml per kg, 0.1 ml per kg to 0.3 ml per kg of adrenaline. How to give this adrenaline? Very simple. You have umbilical vein, patent umbilical vein in the child. Okay, you have cut the umbilical cord. Now take the clamp and using that umbilical vein, you can give this adrenaline. Point number 1. Sir, I could not get umbilical vein. What should I do? This umbilical vein can be used for giving many drugs immediately after, but as patent as it can be patent for 3 to 4 days. You can use it. 1. Sir, if I can't get umbilical vein, what should I do? Very simple. You can use a peripheral. Sir, I am not getting peripheral vein. The child is in shock. What should I do? You have intubated the child now. The same adrenaline can be given through the intubation. I repeat, the same adrenaline can be given through the endotracheal tube. The dosage is 3 times the dosage that we use for IV. So you can use umbilical vein, you can use peripheral vein, you can use endotracheal tube. Is nothing you can't get. Now you can ask me one question, sir. No umbilical vein, no peripheral vein, no endotracheal. I don't know how to intubate. Just I am managing with the bag and mask. What should I do, sir? Simple. Intraosseous IV adrenaline. What intraosseous? You know bone marrow needle now. Take the bone marrow needle and insert into the just below the tibial tuberosity of the baby, just like a bone marrow. And as soon as it reaches the bone marrow, you will lose the resistance and then put a bandage. All drugs can be given through intraosseous route. So who is the savior? The savior is your intraosseous route. So again, sir, apart from adrenaline, can I give any other drug? Apart from adrenaline, can I give any other drug? Whenever any person requires resuscitation, invariably you think that they are in shock. So what is called shock correction? 10 ml per kg of normal saline. What, my dear? 10 ml per kg of normal saline. So you give 10 ml per kg of normal saline followed by adrenaline. Right, so that you need to fill the prevascular compartment. Sir, any other drug previously naloxone? No. Can I use oral? No. Why you can't use oral? Can I use oral? You can't use oral. Why you can't use oral? The answer is very, very simple. Whenever you are in shock, you will get lactic acidosis. Oral always contain lactate, so that it will increase the amount of lactate in the blood. So don't use it. Normal saline is the drug of choice, and adrenaline is the inotrope of choice. Any other thing apart from that you can be used for fluid resuscitation? Yes, O negative blood can be used. I repeat, my dear boys and girls, O negative blood can be used for neonatal resuscitation apart from normal saline. Apart from normal saline, O negative blood. So that's all about neonatal resuscitation. 1 second. Right. So let us revise fastly. Then they will ask you one more question. Sir, the heart rate is more than 100 per minute. I have a child whose heart rate is more than 100 per minute. I have a child whose heart rate is more than 100 per minute, but the respiratory effort is not that significant. Heart rate is more than 100 per minute, there is no need to use bag and mask ventilation, but breathing is somewhat labored, sir. I am not satisfied with the breathing. And the child is having persistent cyanosis, sir. What should I do, sir? Simple. Okay, in that way, what you need to do? Consider CPAP. Consider CPAP. What do you mean by CPAP? CPAP is nothing but positive pressure ventilation. What do you mean by that positive pressure ventilation? Very, very simple, my dear boys and girls. So, what is mean by positive pressure ventilation? Simple. So, you know, whenever you have hypoxia or cyanosis, you will put the baby in oxygen. You will put the baby in oxygen in nasal prongs. So, one end in the oxygen port, another end into the nose. But instead of this, you keep some water column in between your nasal prong, in between your nose and the oxygen port. So what does it mean? So this is the oxygen port. So let me think that this is the oxygen port. So what is that oxygen port? Simple. So let me explain you. Let me explain. So you have oxygen from the wall. That one end can be taken and dipped into a column of water. Dipped into a column of water. Okay, another end will be taken from the column of water and it will be inserted into your inserted as a nasal cannula. So what happens? Instead of coming directly to the nose, instead of coming directly to the nose, the oxygen, okay, goes inside a water column and gets some kind of increased pressure, and a little bit of that oxygen will come out with a little bit of extra pressure. This is called continuous positive airway pressure. What is the use of it? Because it will keep the alveoli distended during expiration. This is called CPAP. So whenever heart rate is more than 100 per minute, but the child is having labored breathing, the child is having persistent cyanosis, you need to go for continuous positive airway pressure CPAP. Right. Shall we revise within a minute? Okay. Remember, and one more point, each and every time people must be asking you, what is the oxygen? Okay. What is the SpO2 immediately after birth, even in normal children? Even in normal children, at 1 minute after birth, it doesn't mean that you need to do a resuscitation. It almost take 10 minutes to attain a saturation of 95%. It takes almost 10 minutes to attain a saturation of 95%, even in normal person. So in the first minute, don't jump into conclusion if the baby is crying. Okay, if the baby is crying but the child is having cyanosis, means wait and watch for about 10 minutes. At the end of 10 minutes, the saturation will become 85 to 95. A crying baby, saturation 85 to 95 at the end of 10th minute means normal. Despite crying, despite after waiting for 10 minutes, if the child is still having some cyanosis, think about cyanotic congenital heart disease, not respiratory problem, because the child is actively crying. Okay, child is actively crying. So, shall we revise within 1 minute? Shall we revise 1 minute? People watching, okay, shall I revise? 30 minutes only for neonatal resuscitation. Let me start again. When the child is born after birth, I will look into three things. What are all the three things? Term baby or preterm baby, crying or not crying. Third one is tone of the baby. When these things are correct, I will do routine care and will hand over the baby to the mother. If I have issues in hypotonia, if the baby doesn't cry immediately after birth, I will do initial steps of resuscitation. What are all the initial steps of resuscitation? Receiving the baby in pre-warmed towel, keeping the baby under a radiant warmer, keeping the baby in the sniffing position. Okay, suctioning of the mouth followed by suctioning of nose. And finally, dry the baby and delayed cord clamping, clamping the cord 30 seconds to 60 seconds after birth. So, 6 points in initial steps of resuscitation. Second, the child doesn't cry after birth. After 30 seconds, I will do tactile stimulation. What is called tactile stimulation? Gentle tickling of palms and soles and gentle rubbing of the spine. Okay, what will happen when the child doesn't cry within 1 minute? The child is said to be in primary apnea. Primary apnea means heart rate will be low, but BP will be normal. When you do tactile stimulation, the child will pick up. That's it. Tactile stimulation. At the end of 1 minute, that still the child is not crying means what I need to look for. I will look for three things: whether the child is having labored breathing, apnea, heart rate less than 100 per minute. Okay, the child is now having heart rate of more than 100 per minute, a persistent cyanosis, and labored breathing instead of gasping means what I told you just now. Instead of positive pressure ventilation, you need to put the child on CPAP. If gasping, heart rate is less than 100 per minute, and if heart rate less than 100 per minute, gasping or apnea means positive pressure ventilation. Positive pressure ventilation means with the help of an ambu bag. How many ventilations per minute? 40 to 60 breaths per minute, and you need to give a pressure of 40 centimeter. Okay, 40 centimeter in the initial. So first thing should be little bit heavy, followed by half of the pressure that you need to do. This is called positive pressure ventilation. At the end of at the end of 15 seconds of positive pressure ventilation, you need to assess the heart rate. Heart rate more than 100 per minute, discontinue bag and mask. Heart rate more than 60 but less than 100 but increasing means continue bag and mask. Heart rate is more than 60 less than 100 but not increasing means ventilation correction steps. What are ventilation correction steps? Mr. Sopa: apply mask properly, reposition the neck, suctioning of the mouth again, open the mouth, adequate pressure, and finally, if nothing, if despite all this, the child doesn't, heart rate is not increased, means alternate steps. What are all the two alternative steps? If you are well versed enough to put an endotracheal tube, put an endotracheal tube. If you are not well versed, put laryngeal mask airway. Right. Now, so you have started positive pressure ventilation. Despite 30 seconds of positive pressure ventilation, if the heart rate is still less than 60 per minute, you need to start chest compression. What are all the two chest compressions? One is two thumb technique, another is two finger technique. What you need to use? Two thumb technique. What is the cardiopulmonary resuscitation? 3 is to 1 ratio. How 3 chest compressions and 1 ventilation. How many events per minute? 120 per minute. So if the heart rate is still less than 60 per minute, at the end of 1 minute of CPR, if the child doesn't cry, what the drug you need to use? Adrenaline. What power of adrenaline? 1 in 10,000 adrenaline. What is the dosage? 0.1 ml to 0.3 ml per kg of normal, 0.3 ml per kg of adrenaline, followed by normal saline bolus. Okay, what are all the routes? Umbilical vein, peripheral vein, endotracheal tube, intraosseous route. These are all the routes, right? So that's all. Points about neonatal resuscitation is over. Okay, so what are all the things I told you? So positive pressure ventilation, bag and mask. You need to draw bag and mask ventilation. Okay, so term baby means always you need to give 100% oxygen when you give bag and mask. 100% oxygen when you give bag and mask. For preterm babies, even high oxygen content is somewhat injurious. So you use 30 to 60% of oxygen concentration rather than 100%. Okay, indication of bag and mask ventilation, they will be asking you. Apneic, gasping, heart rate less than 100 per minute. Okay, these are all the indications for bag and mask ventilation. So these things have been discussed in detail. Mr. Sopa, I told you, inadequate seal, blocked airway, suctioning, open the mouth, adequate pressure, consider alternate airway. Okay, again discussed. So two thumb technique should be used rather than two finger technique. What is the indication of chest compression? Heart rate less than 60 per minute after 30 seconds of positive pressure ventilation. Okay, again chest compression. Okay, right. Endotracheal intubation. This is also, I don't think this will be asked to you in your it will be asked in your NEET or next, not with respect to your essay question. But if at all you want to say something, look at this internal diameter of the tube 2.53, 3.54. Usually for term babies, 3.5 mm internal diameter tube should be used. So if someone is asking you in Viva OC what ET tube you usually use for a term baby, means 3.5 mm. For a preterm baby less than 2000 means you say 3 mm. Remember, less than 1000 gram means small size tube 2.5. 1000 to 2000 means 3. 2000 to 3000 means 3.5 mm ET tube should be used. Just remember, just have a look into it. 3, 2.5, 3, 3.5. Less than 1000, 1000 to 2000, 2000 to 3000. That's all. You will get a good mark for this. Endotracheal tube. So what else? Medications. What are all the two medications I told you, my dear boys and girls? Inotrope is adrenaline 1 in 10,000. Normal saline 10 ml per kg. Apart from that, what can be used? O negative blood. Will you use RL? No. The answer is no. Will you use methoxone? No. These are all before 2015, not now. Okay, right. So these are all the classes. So these are all the notes given in your app. So these things were discussed right now in detail. So the first 45 seconds we have taken for neonatal resuscitation, an important essay question. Essay question. So in short, it is given here. In short, it is given in your app. You can go through it. Okay. So preparatory thing, sniffing question, everything. And one more point, people will be asking you, in case of meconium staining, will you use bag and mask ventilation? Previously, before 2010, when meconium staining is present, people used to say you need to put an endotracheal tube, take the meconium that is present in the trachea, then start your bag and tube ventilation. But the current guideline is, even when the baby is having meconium aspiration, bag and mask ventilation can be done. Why? Because when you don't start bag and mask ventilation, by the time you searching for your endotracheal intubation, the child would have gone for birth asphyxia. I repeat, even in meconium aspiration, bag and mask ventilation can be done, right? So these are all the treatments offered by us to that child. Okay, so right, I told you, no, laryngeal mask airway. Look here. So this is your mask, like it is just like an endotracheal tube. but at the end of the tube you have a mask. So when you keep this and insert blindly into the through the mouth, this area will go and hitch over the laryngeal inlet, so that this end you can connect back and this end will be over the laryngeal inlet. So this is called laryngeal mask airway. Another can be a 2 mark or 5 mark question for you. Laryngeal mask airway is very very important. When you don't know how to do laryngeal when you don't know how to intubate, the emergency procedure of choice to initiate ventilation is laryngeal mask airway. Another short notes. So what is this? This is for, okay, so you can put some water or air so that it will stay inside the over the laryngeal inlet. So this is called laryngeal mask airway steps. Okay, right. Now, next question. So, neonatal resuscitation is over. Now, write a short notes on Apgar in resuscitation. So, you all know that when someone is asking what is called Apgar, what is called Apgar, means there are 5 points with respect to Apgar. So, what does Apgar indicates? Apgar indicates whether your respiration is intact, whether your circulation is intact. I repeat, whether your respiration is intact and circulation is intact. What are all the 5 points with respect to Apgar? So what are all the 5 points? A stands for appearance. So what are all, and Apgar indicates you can give score of 0, 1, 2. How many criteria you are taking? You are taking 5 criteria. Each criteria will be given a score of 0, 1, 2. So what is the minimum score? 5 into 0. What is the maximum score? 5 into 2, 10. So minimum score will be 0, maximum score will be 10. So this is the first thing that you need to write in your question paper, answer paper. Very, very important. So what are all the things that you need to know in Apgar? A stands for appearance. If both peripheries, that is your fingers are pink and mouth is pink, you give a score of 2 because the child circulation is fine. 1. Second point, your pink central but peripheries are blue, means you will be given a score of 1. If the entire thing is blue, means you will be given a score of 0. So this is with respect to appearance. Second, pulse. More than 100, less than 100, no pulse. More than 100 or 2, less than 101, no pulse means 0. Grimace means whenever, okay, so when you do nasopharyngeal suction, you put some tube into the nose. Now at the time the child will just try to pull the neck out of your hand. So what does it mean? When the child cries and pulls away, it means the child is active. You give a score of 2. When the child is having, instead of just pulling it, just smiles and trying but not doing, means give you a score of 1. When there is no stimulation, when there is no response, even when you keep one NG tube into the nose, means when there is no response, means it is given a score of 0. Activity. What do you mean by activity? When both upper limb and lower limb as well as the entire spine is in the flexed posture, active movements, means you are giving a score of 2. You are giving a score of 2. But what happens when the child, when arms and active movement, the child is actively moving, both upper limbs or lower limbs are actively moving, means you are giving a score of 2. The child is not moving the limbs properly, but it is in flexed posture. So some amount of oxygen reaches the brain, some amount of the tone is maintained. So you are giving a score of 1. When there is no movement and the child is in frog-leg position with complete hypotonia, means score of 0. Respiration. Strong cry indicates that the child has established respiration. Irregular breathing, you are giving a score of 1, and no breathing, you are giving a score of 0. This is very, very important. Remember, so appearance, pulse, grimace, activity, respiration. So Apgar can be a question for you in your short notes, as well as one more question they will ask you. They will give some of the findings with respect to Apgar in your entrance examination. How they will ask you: a child is born immediately after birth. The child is entirely blue, score 0. But the child heart rate is less than 100 per minute, score 1. The child is showing no response to any stimulation, again score 0. Activity minimal flexion, you are giving a score of 1. Respiration slow. So in that way you can calculate the Apgar. So they will give you one case scenario, they will mention all these points and they will ask you calculate the Apgar score. So minimum is 0, maximum is 10. So what is the use of this Apgar? What is the use of this Apgar? So let's see. Apgar score is an objective method of evaluating the newborn condition. It is generally performed at 1 minute, again at 5 minutes after birth. Performed at 1 minute and again 5 minutes after birth. Then they will ask you one beautiful question in your examination or in your viva. What is that? Will you use Apgar for neonatal resuscitation? I am waiting for your answer in comment section. Will you wait? Will you use Apgar before neonatal resuscitation? I am waiting for your answer. No. Why? Your resuscitation should be started immediately after birth. But Apgar is scored only at the end of 1 minute. At the end of 1 minute, if the child doesn't cry, what you are supposed to do? Already you had finished initial steps of resuscitation. Already you had finished tactile stimulation. So by the end of 1 minute, if the child doesn't cry, you are going for positive pressure ventilation. That's why, my dear kids, you are not going to rely on Apgar score for neonatal resuscitation. This point should be mentioned in your answer sheet. This point should be mentioned in your answer sheet. Which one? Apgar score is not necessary for neonatal resuscitation. And remember, and then extended Apgar, and then every 5 minutes you can score Apgar for up to 10 minutes if 5-minute Apgar score is less than 7. So if Apgar is more than 7, the child has been doing well. Why should I monitor the child again and again? But if the Apgar is less than 7, I need to monitor the child. So for every 5 minutes, if the Apgar score is less than 7, I will put Apgar scoring till the Apgar score is more than 7, so that you are monitoring the child. Apgar score is nothing but monitoring of the circulatory status, respiratory status and neurological status. So what are all the things you need to mention? 5 points. 0, 1, 2, minimum score, maximum score, not necessary for neonatal resuscitation, and more less the Apgar means more chances for birth asphyxia, and more chances for birth asphyxia, and what else? That's it. So this is all about your Apgar. A single page is more than necessary. This is a short notes. Apgar score, definitely a short notes in the form of clinical scenario. Okay, it can be also asked in your Viva OC, right? Apgar scoring is over. Then enumerate the normal findings in newborn. Remember, there are so many things that can be seen, that can be scary to the mother, that can be scary to the to your intern for a 4th year, but they are absolutely normal for a newborn. So what are all the things? So let me show you photographs. Let me show you photographs. So remember, one by one, very, very important photographs. So look into these photographs. So what are this? So these are all called, so you could see some whitish nodular things in the gingiva. Whitish nodular things in the gingiva. What is this? This is called bone nodules. BAHN, bone nodules. This is absolutely normal. So this is called bone nodules. This is absolutely normal. Second one, you could see some kind of crustaceans in the upper and lower lip. So what is this? This is nothing but sucking blisters. This is also normal. This is nothing but sucking blisters. This is also normal. Second point. Okay. Now you have some blisters, okay, shown here. Whenever you have these kind of blisters in the newborn, it can be one erythema toxicum. It can be erythema toxicum. Erythema toxicum, in which there is no infection, but there are eosinophils in the blisters. there are eosinophils in the blister. This is called erythema toxica. When it contains neutrophils, but no organisms, means it is called benign pustular melanosis. This is called benign pustular melanosis. This is called benign pustular melanosis. Third, if it contains neutrophils along with staph aureus, then it is infection. You need to give antibiotic. The first erythema toxicum, no need for antibiotic. Second one, neutrophil without any organisms, benign pustular melanosis, no antibiotic, reassurance. But neutrophils are present, staph aureus is present, means then the child has to be treated with the first generation cephalosporins such as cephalexin or cefadroxil. Okay, right. Now look at this. The angle of mouth is deviated. That angle of mouth is deviated. What is the difference between these two? What is the difference between these two? The angle of mouth is deviated in these two kids. So what is the difference between these two? Remember, in this case, nasolabial fold is preserved. I repeat, in this case, nasolabial fold is preserved. When nasolabial fold is preserved, but angle of mouth is deviated to one side, means that it means that there is absence of depressor anguli orifice in this side, on the right side. Here on the left side, the angle of mouth is deviated to the left side. So what happens? There is one condition in which depressor anguli oris on the opposite side will be absent. As a result of which it will be the other side unhindered contraction of the depressor anguli oris on this side is pushing it, so that angle of mouth is deviated to that side. How to differentiate? But as far as a final year is concerned, one thing that should be taken into consideration, what sir, it is lower motor neuron facial palsy. In lower motor neuron facial palsy, you will have this angle of deviation of mouth. Why can't it be lower motor neuron facial palsy? Very, very simple. Look at the nasolabial fold. If the nasolabial fold is not seen, it is a case of seventh nerve palsy. It is a case of seventh nerve palsy. Whereas when nasolabial fold is preserved, means it is a case of depressor anguli orifice absence on the other side. Very simple. Okay. So deviation of angle of mouth. A child smiles with a deviated mouth, means nasolabial fold present on both sides. It is a case of absence of depressor anguli orifice. Nasolabial fold absent means facial nerve palsy. Right? Right. Now, what is this? You can see some keratin filled cyst in the heart palate. You can see some keratin filled cyst in heart palate. So what is this? This keratin filled cyst in heart palate is nothing but Epstein's pearls. What is this? This is called Epstein's pearls. Keratin filled cyst in the heart palate is called Epstein pearls. So what is this? I told you, absent depressor anguli oris, because nasolabial fold is present. What is this? Nasolabial fold is absent. So this is seventh nerve palsy. Is seventh nerve palsy. So these are all the normal things. Okay, again, what is this? Small cystic lesions in the nose. So this is called sebaceous hyperplasia. This is called sebaceous hyperplasia. This is called sebaceous hyperplasia. And what is this? Look at this. There is some conjunctival hemorrhage. This is called subconjunctival hemorrhage. Subconjunctival hemorrhage. This subconjunctival hemorrhage is normal. This subconjunctival hemorrhage, even that retinal hemorrhage can be seen normal. Finally, look at this: born nodules, sucking blisters, pustules. Pustules with eosinophil, with neutrophils. With neutrophils means with infection, without infection. Depressor anguli orifice, seventh nerve palsy, Epstein's pearls. Okay, Epstein's pearls, sebaceous hyperplasia, subconjunctival hemorrhage. 1, 2, 3, 4, 5, 6, 7, 8. All these things are normal except this one. Watch carefully. Except this one, this is not normal. Why this is not normal? This is pathological. This is pathological. So what is this? There is reddening, woody induration of skin. This is called as sclerema. This is called as sclerema. I repeat, this is called as sclerema. Red, this red woody induration of the fats involving your chest and back is called sclerema, and this is pathological. This occurs in end stage gram negative sepsis. What? Gram negative sepsis, and this is called as sclerema, and it is a manifestation of severe sepsis. Most commonly it can occur as a result of pseudomonas infection. Any infection, indeed, it indicates grave prognosis. When sclerema is present, it indicates that the child is having bad prognosis. Because of sclerema, woody induration of the chest and back, the respiration will not be proper, leading to demise of the child. So 1, 2, 3, 4, 5, 6, 7, 8 are all normal, whereas this sclerema is pathological, and indeed it indicates the child is going to die, right? The child is going to die, right? Thank you. So this is very, very important, my dear boys and girls. These are some of the skin and oral manifestations of a normal baby. Okay, then, right, another normal thing. So what is this? What is the difference between caput succedaneum and cephalohematoma? Caput, question number 4. So we had completed neonatal resuscitation, Apgar scoring. Third one is what is that? Normal things in a term baby. And now write the differences between a caput succedaneum and cephalohematoma. This is the most favorite questions for an external examination, most favorite question in an university short notes, and it will lead to some sort of confusion in NEET or next examination. So what are all the three types of swellings you know? What are all the three types of swellings with respect to caput and cephalohematoma? With respect to head swellings, I can say head swellings. So what are all the swellings? Look at this. So this is a famous actor called Vadivelu, taken from two different movies. So in one there is swelling over the parietal bone, in another over the presenting part. So what is this? So one is cephalhematoma. One is cephalhematoma. Let me explain it. Wait. One is cephalhematoma. Another one is caput succedaneum. Another one is caput succedaneum. So one is cephalhematoma. Another is caput succedaneum. What are all the things that you have in this? So let's see. Okay, caput means what? Caput means when the child tries to come out through the vagina, the presenting part will be hitching the vaginal orifice for a long period of time. As a result of it, there is a venous stasis, and some amount of fluid will be accumulated because of the back pressure produced by the vaginal outlet. So this is subareolar fluid. This is subcuticular, sub skin, subcuticular fluid. So a simple fluid, it is not blood. Which one? Caput. So caput occurs as a result of normal vaginal delivery, pressured offered by the vaginal outlet. It is, since it is during, it occurs during the process of birth, It is present immediately after birth. When the child is born, if you see some swelling, it is caput unless otherwise proved. It is caput unless otherwise proved. So caput. How what is the management of choice for caput? Keep quiet. Nothing you can do. It doesn't mean that you need to put some massage over the swelling. Just wait. It will go within a week. I repeat, it will go within a week. So caput is subcuticular fluid. It doesn't contain any blood. It is present over the presenting part. It occurs on the same day after birth and it resolves within 3 to 5 days. This is called caput. This is called caput. Whereas what is called cephalohematoma? Cephalohematoma is a subperiosteal bleed, which usually leads to cephalohematoma. Cephalohematoma usually arises in cesarean delivery. Cephalohematoma usually occurs in a cesarean delivery. So, in a cesarean delivery, what will happen? There will be, or not cesarean, I am extremely sorry, forceps delivery. Cephalohematoma is a manifestation of a forceps delivery. So what happens? There will be some amount of pressure that offered to the parietal bone, leading to fracture. This fracture leading to subperiosteal bleed. So subperiosteal bleed. Cephalohematoma is a subperiosteal bleed. So what will happen when the child comes out? When the child comes out, immediately you can't see the bleed, because as soon as you put some pressure over the forceps delivery, the child has come out. But because of the fracture, slow accumulation of the blood that occurs in the periosteum, so cephalohematoma is usually visible on the third day or fourth day after birth. It doesn't present immediately after birth. But like caput-hematoma, it won't disappear within a week. Since this is a blood clot, it takes almost 2 to 4 weeks to disappear. Sometimes this cephalomotoma will not disappear and can undergone calcification, leads to persistent swelling of cephalomotoma, leads to persistent swelling over the head. This is called cephalometoma. And one more beautiful point is caput is a subcuticular fluid. So it usually crosses the sutures. It can present here, 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 everywhere. But cephalometoma is a subperiosteal bleed. So it will be confined to one bone. So as a result of which, it won't cross sutures. Very, very important. It won't cross sutures. Which one? Cephalometoma won't cross sutures. So these are all the two major things that you need to know, right? So caput caput is a diffuse body pitting swelling, non-fluctuant, whereas cephalometoma is a fluctuant one. Level of swelling, this is subperiosteal collection, whereas over the broken bone, parietal bone, and this is over the presenting part. Caput is present at birth, whereas cephalometoma takes 3 days to appear. Caput crosses suture. Cephalometoma doesn't cross suture. Cephalometoma is associated with skull fracture. Is associated with skull fracture. What is the management of choice for caput? The management of choice for caput is observation, whereas the management of choice for cephalometoma is observation. But if there is an abscess formation, drain it. If there is hyperbilirubemia, this is a concealed bleed. When when the RBCs that are present in the cephalometoma breaks, it can lead to prolonged jaundice too. So in those instances, you can do an IND and evacuate the blood. IND means incision and drain it. IND, and you can take the pus out. Third point is calcified hematoma. If it will be persistent, and it should be surgically excised, Okay. Now, what is subgaleal bleed? What is subgaleal bleed? So remember, first one is subcuticular bleed, second one is subperiosteal bleed. Third one, you all know that our head contains a special uh, thick plate, sheet-like a substance called subgaleal aponeurosis. Whenever you have a bleed that is below the below the subgaleum, that is called subgaleal hematoma. So how do I differentiate between caput cephalometoma and subgaleal bleed? Caput, uneven full delivery. Cephalometoma, forceps delivery. Subgaleal means it is a diffuse bleeding under the entire calvarium, and it is present below the subgaleal, and it is present below the gallia aponeurotica. How do I know? The child will be very, very, very sick. Caput, the child will not be sick. Cephalometoma, based on the forceps delivery, may or may not be sick. But in subgaleal bleed, the child will be invariably sick because it is a diffuse bleed that occurs due to vitamin K deficiency. Diffuse bleed in such a sense that extensive amount of blood just below the subgaleal area, as a result of which the child would have gone for shock. So FFP will be necessary, blood transfusion will be necessary, shock correction will be necessary, vitamin K will be necessary in case of subgaleal bleed. I repeat, in case of subgaleal bleed. So these three types of bleeding are very, very common in newborn. Three head swellings. Epidural hematoma, we don't get in newborn. Okay, caput immediately after birth does cross a suture. Cephalometoma occurs 3 days after birth, doesn't cross suture. Caput crosses suture. Cephalometoma doesn't cross suture. Both of them, first caput, child will be normal. Cephalometoma may have an underlying forceps delivery history of. Subgaleal hematoma, child will be very sick. How do I know, sir, that the child is having subgaleal hematoma? When you have some sort of swelling in and around the orbit, in and around the ears, you are dealing with a case of subgaleal bleed. This point will give you very, very, very good marks in your short notes. I repeat, when you have a swelling in and around the ear and swelling in and around the eyes means swollen eyes, swollen ears around the ear means it is a case of subgaleal hematoma. The child will be in shock. You require vitamin K, FFP, blood transfusion, shock correction. Okay, so look at this fluctuant swelling over the entire calvarium. As I told you repeatedly, periorbital edema, blood, auricular edema, blood here, massive collection of blood, okay, in the subgaleal area. Again, this is also not limited by sutures. It leads to anemia, jaundice, shock, infection. As I told you already, vitamin K, blood transfusion. Again, this is also a bleed, can lead to jaundice, can lead to prolonged jaundice. So this is what we have discussed is about head swellings. Caput, cephalometoma, subgaleal bleed. Caput, cephalometoma, subgaleal bleed. So this is our third short notes. First long answer is neonatal resuscitation. Second short notes, Apgar. Third short notes, what are all the normal findings in your newborn, skin findings and mucosal findings in your newborn. Fourth one is head swellings we have dealt with. What? Head swellings. Right. Now, tabulate the differences between symmetrical and asymmetrical IUGR. What do you mean by IUGR? So IUGR is a morphological definition. IUGR is a morphological definition. So what do you mean by IUGR? IUGR means intrauterine growth retardation. You all know IUGR is nothing but intrauterine growth retardation. What is the normal weight of the child? The normal weight of the child at birth is usually should be more than 2.5 kilograms. So when a preterm is born, birth weight can be low. That is acceptable. That is acceptable. When a child is born by 32 weeks, it can be invariably around 1.5 kg is acceptable because at 32 weeks the child should be 1.5 kg is accepted. But at term, if the child is 3 kg is accepted. But a 37 weeker with a weight of 2 kg means what? The child is having some small for gestational age. Sir, what is called small for gestational age and what is called IUGR. Small for gestational means it is a statistical definition. It is a statistical definition. Okay, what do you mean by statistical definition? When the weight of the child for that particular gestational age is less than 10th centile, I repeat, when the age of the child is less than 10th centile at birth, we will call it as small for gestational age. It is a statistical definition. Sir, what is this percentile? 10th centile means what? I can't understand. Very, very simple. So let me think that 100 people are watching this video. When 100 people are watching this video means, let me say, let me ask 100 of you to sit based on the increment of your height. The first person can be 50 kg, second person can be 51. In this way I will ask you to sit in the ascending order. So first person will be 50 kgs, second person third 51, third person 52, fourth person 52.5, etc. In the same way I will ask you 100 of you to sit based on the ascending order of the weight, or it can be height also. This is called a cohort. So 10th centile means, what does it mean? In this group, the first 10% are below on par with this ethnicity. So this last first 10 people are not up to the mark. They are low for this group. This is called 10th centile. The last 10%, 90 to 100 means they are over for this age group. So you can neither be in the first 10, you cannot be in the last 10. If you are in a first 10, you are small for that group. If you are after 90th means you are large for that group. You can neither be small nor can be large. You can be normal. What is normal? 11th candidate to 90th candidate is normal. More than 90, reduce your weight, I will say. First 10, increase your weight. So this is called statistical definition. So what is called small for gestational age? Less than 10th centile is called small for gestational age. What is called AGA? Appropriate for gestational age. 10th to 90th centile is called appropriate for gestational age. What is called large for gestational age? More than 90th centile is called large for date. More than 90th centile is called large for date. Very, very important. So I repeat, whenever any child is born less than 2.5 kgs, it is called low birth weight. It is called, so less than 2.5 kgs means it is called low birth weight. So either it can be a preterm or it can be a term. Preterm means that low weight is acceptable, but term baby less than 2.5 kgs is not acceptable. Okay. So less than 10th centile, small for gestational age. 10th to 90th centile, appropriate for gestational age. More than 90th centile, large for gestational age. Sir, you told small for gestational age is called statistical definition. What is IUGR? IUGR means intrauterine growth retardation. I repeat, intrauterine growth retardation. The ability of the child to grow inside the uterus is not on par with the normal child. Why the child is not growing properly, sir? Very simple. Very simple. And how do I know the child is having intrauterine growth retardation? Very simple. When you are not given any food properly, what will happen to you at the end of 15 to 20 days? You will lose all your buccal pad of fat. You will lose all your buccal pad of fat. You will lose all your uh, fat that is present in the gluteal region. So when you lose all your buccal pad of fat, you will become like this. What is this? This is called monkey faces. This is called monkey faces. When you lose subcutaneous tissue fat in the gluteal region, you will have folds of skin in the gluteal region. That is called baggy pant appearance. Now you tell me what is called morphological IUGR. Morphological IUGR means the child is not on par with the weight as per the age. One. Second point is weight of the child is low, less than 2.5 kilograms. They will have signs of loss of subcutaneous fat in the form of monkey faces and baggy pant appearance. When you have this kind of morphological features of monkey faces and baggy pant appearance, this is called IUGR, and that's why we call it as morphological definition. This is not a statistical definition. This is a morphological definition, whereas small for gestational age is a statistical definition. This question will definitely be asked in your Viva OC too. Now, okay, now I have a child with the small for now I have a child with the baggy pant appearance and monkey faces. Now, how do I know what had happened in the in utero? What insult had happened in utero? Very, very simple. What insult had happened in the in utero? Very, very simple. Okay, so the insult would have happened in the first trimester, or the insult would have happened in the last trimester. If the insult had happened in the first or second trimester, what will happen? Both your head circumference and your abdominal growth, abdominal organs will be affected. So, what we call it as symmetrical IUGR. Symmetrical IUGR means it is also not grown properly. Abdominal growth, internal organs is also not grown properly. This is called symmetrical IUGR. Symmetrical IUGR means head is involved. So what will happen? What are all the causes? First trimester or second trimester causes. What are all the causes? Majority it can be due to torch infection. It can be maternal toxoplasmosis, syphilis, rubella, cytomegalovirus, herpes, so many things. So symmetrical IUGR means either it can be torch infection or aneuploidies. What are aneuploidies? It can be a Down syndrome, or it can be a Patau syndrome, or it can be a Edwards syndrome. Symmetrical IUGR means the child is not going to catch the weight and the height even after birth, because already the child is infected, already the child is having some chromosomal anomaly. That's it. So when the head is involved, symmetrical IUGR, first trimester hit, second trimester hit, prognosis will not be that good. Prognosis will not be that good, causes aneuploidy torch infection. Always a complicated neonatal score. Always a complicated neonatal score. What is called asymmetrical IUGR? Asymmetrical IUGR means the insult had occurred in the third trimester. In third trimester, by the time the child is affected by in the third trimester, the head would have gone properly. So what will happen? The head will be spared. Only the abdominal organs will be affected. So what will happen? Head is normal, but body is affected. Means this is called asymmetrical IUGR. Majority of asymmetrical IUGR are mainly due to poor placental blood flow, or otherwise known as placental insufficiency. Placental insufficiency, underlying placental insufficiency. So what will happen? The child will be finally normal. After some initial hiccups can be there, but usually the child will pick up weight and height, everything after some weeks after birth, if proper caring is given. Proper care is given. That's it. So symmetrical IUGR first trimester, second trimester hit. Asymmetrical IUGR head is fat. Symmetrical IUGR first trimester IUGR cause aneuploidy torch infection. Asymmetrical IUGR placental insufficiency. Symmetrical IUGR torrential course. Asymmetrical IUGR good course. Right. How do I know? How do I know whether it is symmetrical or asymmetrical IUGR? For that, you need to know ponderal index. So this is a short notes for you. And what is called ponderal index? So it is a formula. This can be a 5 mark question also. Okay, this can be a 5 marks question also. What is called ponderal index? What is called ponderal index? Very, very simple. Okay, so ponderal index means weight of the child in grams. So let me say 1.5 kgs means 1500 grams. Length of the child in centimeter. So usual length is 50 centimeter. 50 centimeter. 50 into 50 into 50. All to the power of 3 into 100. Into 100. Okay, so let me say 150 divided by 25. So this is called ponderal index. So what it comes around 6. So what is the use of this ponderal index? Remember, a ponderal index of less than 2 is asymmetrical IUGR. A ponderal index of 2 to 2.5 is symmetrical IUGR. A ponderal index of more than 2.5 is normal. Less than 2 asymmetrical, more than 2 2.5 normal, more than 2.5 is abnormal. So remember ASN, ASN, AS Nadrajan or AS something you know, because ASN, A stands for asymmetric, S stands for symmetric, N stands for normal. Less than 2.5, 2.5 to less than 2, 2 to 2.5. Normal means more than 2.5. Again, ponderal index is an important question in your Viva OC, short notes as well as in your NEET or next examination. Very, very important. Ponderal index, you need to know. Many examiners are fond of asking this question. When they ask a ponderal index in short notes, but you know only this much, add that symmetrical IUGR and asymmetrical IUGR, that 3 to 4 points. That will be very, very useful to complete the page as well as to get a good mark. Okay. So IUGR is a morphological definition, monkey faces and baggy pant appearance, whereas STI is statistical definition. So again, what are all the points that is given in our app? So thin, slender look, because he is born with poor, is born not giving any proper food to him. Loss of folds of wrinkles in skin, monkey faces. Remember, this IUGR babies are more prone for many complications. So what are all the complications? Because of loss of subcutaneous fat. You all know that fat is nothing but a insulation against hypothermia. When fat is not there, the child is prone for hypothermia. So compared to preterm, this SGA small for IUGR baby is more prone for hypothermia. Meconium aspiration. Why meconium aspiration? The child is not fed properly. As a result of which, the child will go for fetal distress, and the child, as soon as the child go for intrauterine fetal distress, the child will try to aspirate the meconium at the time of birth. And again remember, IUGR has a poor neurocognitive development, particularly if it is a symmetrical IUGR, because of the involvement of head in case of symmetrical IUGR, right? So IUGR is a morphological definition due to constraints in fetal nutrition during the crucial period of brain development, right? So this is about IUGR. IUGR, as well as one more question is what? One more question is what? Ponderal index. Weight in grams divided by height in centimeter whole to the power of 3 into 100. Less than 2, asymmetric IUGR, ASN. Okay, symmetrical IUGR 2 to 2.5. More than 2.5 is a normal child, right? Okay. So, right. Now, okay, what is this? Define perinatal asphyxia and explains its essential diagnostic criteria. Describe the stages of hypoxic ischemic encephalopathy and how these stages help predict prognosis. Okay, any child who doesn't cry immediately after birth will be in a state of perinatal asphyxia. As a result of hypoxia, there will be some issues with respect to the neurological outcome. So, what we say, when the child doesn't cry immediately after birth, we will call it as hypoxic ischemic encephalopathy. What? Hypoxic ischemic encephalopathy. And this hypoxic ischemic encephalopathy will go in stages, and you are resuscitating a child, but based on the resuscitation or based on some other situation, the child can be either in mild hypoxia, moderate, he would have got moderate hypoxia, or would have got severe hypoxia. What we call it as hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy. So it occurs in stages. Initially mild, then becomes moderate, then becomes severe. And this classification of mild, moderate, severe birth asphyxia, this progression of mild, moderate, severe birth asphyxia is classified by a famous person, two-person called Sarath and Sarath staging. What is that? Sarath and Sarath staging. What is called Sarath and Sarath staging? It is nothing but stages of hypoxic ischemic encephalopathy based on certain clinical parameters. Why you need to classify a child on HI stage 1 mild, HI stage 2 moderate, and HI stage 2 severe? The answer is very simple. When the child had undergone HI stage 1 and recovered, means there are very high chances for the child 100% neurological recovery. But when the child had gone for HIE stage 2, HIE stage 2, it means 20% of those child can have some form of neurological issue in the form of spasticity. You all know that cerebral palsy. What we call it as cerebral palsy. When the child had gone for stage 3, HIE stage 3, severe neurological damage. So what will happen? 50% morbidity, 50% morbidity and 50% mortality. In HI stage 3, 50% of those child will die. Even if the child is alive, definitely there will be some cerebral palsy. Okay. Right. So what did I say? In case of mild HIE, 100% neurological recovery. In case of HIE2, in case of HIE2, only 20% will be affected. Only morbidity. There is no mortality. Morbidity in the form of cerebral palsy. When the child had gone for HIE stage 3, 50-50, that both 50-50 is a loss to you. 50% morbidity, 50% mortality, 50% of them will die, and remaining 50% will definitely have got some form of cerebral palsy. Better having that kind of child, that child would have gone to death. It's very, very difficult to have a normal child when the child has got HI stage 3. Now the mother is asking you, doctor, how you are telling that my child is in stage HI1 or HI2 or HI3? You are asking your assistant professor or senior postgraduate, sir, how do I know my child is in HI stage 2 or HI stage 3 so that I can counsel the mother who is standing outside and crying? Then you need to know what are all the points in favor of HI stage 1, stage 2, stage 3. What is that classification called as? Sarath and Sarath classification. This is called as what? Sarath and Sarath classification. Right. So remember, when the child doesn't cry after birth, it is called perinatal asphyxia. What is called hypoxic ischemic encephalopathy? This perinatal asphyxia usually involves mild, moderate, or severe birth asphyxia. And mild birth asphyxia, HI stage 1, 100% recovery. Moderate birth asphyxia, HI stage 2, only 20% will develop cerebral palsy. Severe birth asphyxia, 100%, 50% morbidity, 50% mortality. Remember that Sarath and Sarath staging. Okay. Right. What is the criteria for perinatal asphyxia? How do I know but my child had gone for hypoxia? Whenever you go, your brain and many parts of the body is deprived of oxygen, what will happen? So perinatal asphyxia is an injury to fetus or newborn caused by insufficient oxygen, which is otherwise known as hypoxia, and also along with that absence of blood flow to various organs, not only brain, leading to, so no blood, no oxygen, leading to lactic acidosis and hypercapnia as a result of CO2 retention because of poor blood supply to lungs also. So what are all the criteria to say that my child had undergone perinatal asphyxia? Very simple. One, lactic acidosis, normal pH is 7.35 to 7.45. When the pH is less than 7.35, it is called the child had undergone hypoxia. Lactic acidosis is a manifestation of hypoxia. Apgar score, persistent score of 0 to 3 for more than 5 minutes. I told you already. What is the normal Apgar score? Normal Apgar score more than 7 at the end of 5 minutes, no need to do anything. But persistent Apgar score of 0 to 3, maximum Apgar score is 10. Okay, if the Apgar score is 0 to 3 for more than 5 minutes, it indicates that the child is definitely going to suffer from some sort of hypoxic ischemic encephalopathy. Neurological manifestations in the form of seizures, lethargy, hypotonia, or manifestations of brain involvement or multi-organ dysfunction doesn't mean that only your brain will have some sort of involvement. If heart is involved, CCF. If liver is involved, neonatal cholestasis or neonatal jaundice or transaminitis. Any organ can be involved. If there is poor blood supply to the kidney, elevated urea and creatinine. So, end organ damage is a manifestation of perinatal asphyxia. pH less than 7. Point number 1, Apgar 0 to 3 for more than 5 minutes, persistent Apgar. Third one is brain involvement in the form of seizures, lethargy or hypotonia. Lethargy or hypotonia. And finally, multi-organ dysfunction. Not only multi-organ dysfunction, not only your brain, but also it can manifest most common organ apart from brain that is affected is kidney. So elevated urea and creatinine in a child born with the birth asphyxia indicates that poor prognosis. Now you know what is called perinatal asphyxia. Perinatal asphyxia means these are all the criteria. Umbilical cord arterial pH less than 7, persistent low Apgar of 0 to 3 for more than 5 minutes, brain involvement in the form of seizures, coma, lethargy, other multi-organ dysfunction, most commonly elevated urea and creatinine or otherwise known as oliguria manifestation, poor urine output. So this is perinatal asphyxia classification. Now my kids need to know what is called mild, what is called moderate, what is called severe birth asphyxia. What is that classification I told you? HIE. Whose classification is this? Sarath and Sarath classification. So let's go for Sarath and Sarath classification. It is not very tough, my dear. It is very easy to remember this Sarath and Sarath classification. Whenever there is mild birth asphyxia, I repeat, my dear boys and girls, whenever there is mild birth asphyxia, the child will be irritable. The child will be irritable. Okay, the child will be irritable. That's all. Child will be irritable, minimal hypotonia, but after 2 or 3 days the child will be normal, no seizures at all. That indirectly goes without saying. But one more point, whenever you are irritable, what will happen to your sympathetic activity? Your sympathetic activity increases. So what will happen as a result of sympathetic activity to your pupil? Meiosis. So meiosis is a manifestation of mild HIE. Meiosis is a manifestation of mild HIE. So mild HIE means meiosis, minimal irritability, minimal hypotonia. What did I say? 100% neurological recovery. Second, when a child had gone for moderate birth asphyxia, what will happen? The child will be very important 3 points with respect to moderate or HI stage 2. One, because of severe moderate insult to the brain, the child will definitely have some seizures. Okay. Whenever any child after birth asphyxia develops seizure, unless otherwise proved, it is in stage 2 of HIE. Okay. And then lethargy directly goes without saying. Hypotonia directly goes without saying. And one more point. Here, parasympathetic activity will be stimulated. What stimulated? In mild HIE, sympathetic activity stimulated, leading to meiosis, whereas in moderate HIE, parasympathetic activity will be stimulated. So what happens as a result of which? Mydriasis. Very important, my dear boys and girls. Mydriasis will be dilated pupil. So mydriasis. Second one is neonatal seizures. Second one is neonatal seizures. Third one, parasympathetic activity leads to increased secretions in almost all parts of the body. Also increased secretions in respiratory system, leading to respiratory distress. Leading to respiratory distress. Leading to respiratory. So what are all the three manifestations of moderate birth asphyxia or HI stage 2? Mydriasis, neonatal seizures, increased respiratory distress. In this, 20% will have cerebral palsy, remaining 80% will be absolutely normal. So seizure, sorry, one is seizure, second one is marked hypotonia, third one is neonatal respiratory distress, fourth one is mydriasis or manifestation of HI stage 2. Third one, severe birth asphyxia. You can't do anything, my dear. You can't do anything. As I told you already, 50% morbidity and 50% mortality. You can't do anything. The child is comatose. The child is comatose. Okay, no response even to painful stimuli. Seizures will be there, long lasting, not responding to your phenobarbital midazolam. There is no spontaneous respiration. You need to intubate the child. What will be the eye finding in this case? The eye finding in this case is mid dilated pupil. The eye finding in this case is mid dilated pupil. Mid dilated pupil in HIE stage 3. Okay, then come on. HIE stage 1, mild irritability, meiosis, 100% recovery. HIE stage 2, mydriasis, parasympathetic activity, respiratory secretion, marked hypotonia, neonatal seizures, 20% morbidity only, no mortality. HI stage 3, end organ damage, no respiration, prolonged seizure, mid-dilated pupil, 50% vertical discharge mortality, remaining 50% will make mothers to die like anything because of severe cerebral palsy. That's it. This is all about Sarath and Sarath staging. Hope my children are very well versed whenever this question is asked. Remember, when you are irritated, sympathetic activity. In HI stage 2, to increase your life, parasympathetic activity is necessary. Third one is you can't do anything, mid-dilated pupil. Meiosis, mydriasis, mid-dilated pupil. Three things you need to remember. Mild temporary hypotonia, moderate hypotonia, severe hypotonia, irritability, lethargy, comatose. Okay? Lethargy, comatose. Okay. Another important, beautiful question. This birth asphyxia has gained so much of importance. You need to know two main things. So remember, in term babies, because of birth asphyxia, because of poor oxygen, what are all the points that is involved? Cortical neurons. So you have brain, you have cortex and you have subcortex. This cortical neocortex will be involved in case of term. Neocortex will be involved in case of terms. Cortical neurons. And when you are in case of mild birth asphyxia, so mild birth asphyxia means cortical neurons will undergo injury, superficial cortex. In case of severe HI stage 2 means deep part. Deep part means basal ganglia, thalamus will be involved. That's why in many centers, if they are not sure with the Sarath and Sarath staging, they will take an MRI. If MRI shows only cortical areas involved, you are safe. It is mild injury. But when MRI involves your basal ganglia and thalamus, it is moderate to severe injury. So taking an MRI after birth asphyxia is prognostic. Cortical neurons alone involve mild. Basal ganglia thalamus involve moderate to severe. You can't help the child. Okay, you can't help the child. And one more point, involvement of this necrosis of basal ganglia and thalamus is otherwise known as status murmuratus. What is that called as? Status murmuratus. And another important question in your Viva OC. Status murmuratus is involvement of necrosis of basal ganglia and thalamus. And finally, parasagittal cerebral injury. So this is your brain, this is your sagittal. When these areas are involved, it is called parasagittal injury. So cortical, parasagittal, status murmuratus occurs in term babies. Term babies. What happens in preterm? Preterm means it is not cortex, it is subcortex. But another beautiful MCQ is, look at this. So this is your brain, this is your ventricle. What will happen? The periventricular white matter are involved. What? Periventricular white matter is involved. So this periventricular white matter is leading to periventricular leukomalacia. In preterm, periventricular white matter is involved. This is called periventricular leukomalacia, in which predominantly lower limb is involved. Predominantly lower limb is involved. As a result of which, the lower limb will go for spasticity, and the increased spasticity of this lower limb is called spastic diplegia. This is called as what? Spastic diplegia. This is called as what? Spastic diplegia. So spastic diplegia is nothing but scissoring grade due to increased tone of the adductors of the lower limb, occurs due to periventricular leukomalacia in preterm babies. So birth asphyxia in preterm babies is subcortical periventricular area. Subcortical and periventricular. Whereas in term babies, cortical, basal ganglia and parasagittal. Very, very important pathological patterns of injury in preterm versus term babies. A very important question in your Viva, as well as in your NEET or next. They will be asking the following are pathological patterns of injury in term babies except parasagittal, status murmuratus, cortical neurons. They will ask periventricular leukomalacia, spastic diplegia, scissoring gait is a manifestation of pathological patterns of injury in hypoxic injury in preterm babies, not in term babies. Subcortical and periventricular leukomalacia is a manifestation of preterm brain injury. Along with that, when you have intraventricular bleed, which is also mainly due to which occurs in preterms rather than in term babies. Okay, pathological pattern of injury. And then treatment, I don't think you need to know much. Now you have a child with birth asphyxia. How you are going to manage the child with birth asphyxia? Very, very simple. So oxygen, first one is temperature. You all know that whenever something is injured or whenever something is going to spoil, to prevent spoiling, what you will do, you will keep things in refrigerator. In the same way, can we keep the child who had undergone birth asphyxia in a refrigerator? No. Instead of which, you need to reduce the temperature of the child. HI stage 1, do you need to keep do you need to reduce the temperature of the child? No, it is going to recover on its own. HI stage 3, whatever you do, there will be some kind of injury. HIE 2, child, the 20% you can save the child. How you are going to save the 20% child? Very simple. You reduce the temperature of the baby. How do you reduce the temperature of the baby? Because by reducing the temperature, you are reducing the metabolism. By reducing the metabolism, you are reducing the superoxide ion radical, free radical mediated injury to the unaffected part of the brain. Whenever you have birth asphyxia, some part of the brain would have been affected by birth asphyxia, hypoxia. Another areas will be normal. But the superoxide free radicals that is produced in the affected area will go and affect the unaffected area. So by reducing the temperature of the child, you can save that child being getting developed to cerebral palsy. This is called therapeutic hypothermia. What is that, my dear boys and girls? This is called therapeutic hypothermia. What do you mean by therapeutic hypothermia? You reduce the temperature of the child. What is the normal temperature? 36.5 to 37.5 degrees Celsius. What is the normal temperature? 36 to 37.5 degrees Celsius. But by reducing the temperature of the child to less than 33.5 to 33.5, you need to know the rule of 33. So less than 33 weeks, don't do therapeutic hypothermia. Therapeutic hypothermia only for children between 33 weeks to 37 weeks. So remember one formula: 34 plus or minus 0.5 plus or minus 34 plus or minus 1. So 33 to 34. Okay. This is the target temperature. The target temperature is 33 to 34. Target age is again 34 gestational age. 34 to 37. Right. So this is called therapeutic hypothermia. A very, very important question. Oxygenation. It doesn't mean that you need to increase the oxygenation more than 95%. Oxygen itself can produce injury. Oxygen should be kept between only 90 to 95. Perfusion. Maintain blood pressure in such a way that mean arterial pressure should be maintained. Blood glucose, maintain between 75 to 100. Not much MCQs. Seizure control with the help of phenobarbital, phenytoin, correct hypoglycemia, correct hypocalcemia, etc. Electrolyte, not much question. So the questions with respect to U is therapeutic hypothermia. So what is the criteria for therapeutic hypothermia? HIE stage 2. What is the minimum gestational age? 33 to 34 gestational age. What is the temperature that you need to reduce to? Only 33 to 34 degree Celsius. It should be started within 6 hours, because if you start the therapeutic hypothermia after 6 hours, the oxygen free radical mediated injury would have happened even before you start. So start within 6 hours, continue for 72 hours, and then slow rewarming over 4 hours, and then slow rewarming over 4 hours. Therapeutic hypothermia itself is a short notes for you. Just write these 6 points, which is more than enough. Two types: either you can cool the body, it is called whole body cooling, but right now they are doing selective head cooling. Right now they are doing selective head cooling. So therapeutic hypothermia is definitely a short notes for you, my dear boys and girls. Okay, again prognosis. HI stage 3, bad prognosis. Persistent abnormal neurological signs even after 1 week, bad prognosis. Presence of oliguria indicates renal injury. If it persists in the first, it is 36 hours, bad prognosis. Absence of spontaneous breathing 20 to 30 minutes after birth is a bad prognosis. So these are all the bad prognosis. So with this, we are finishing our topic for today. Finally, with this. So what is a term baby? A term baby means 37 weeks to 37 weeks to 37 weeks to 41 weeks and 6 days. That is called term babies. In terms of date, 259 to 293 days. What is a preterm baby? Less than 37 weeks or less than 259 days. Preterm. In preterm, you have late preterm, moderate preterm, very preterm. Late preterm 34 weeks to 37 weeks. Moderate preterm 32 weeks to 33 weeks and 6 days. Severe very preterm means 28 weeks to 31 days and 6 weeks. 3 classification. What is called post-term? 42 weeks and above or more than 293 days. Perinatal period, this is very, 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 very important. Perinatal period. It is not 28 weeks, I repeat, it is 22 weeks of gestational age to 7 days after birth. Low birth weight to less than 2500 grams. Less than 1000 grams, very low birth weight. Less than 1500 grams, very low birth weight. Less than 1000 grams, extremely low birth weight. Statistical definition: less than 10th centile, small for. 10 to 90th centile, appropriate. More than 90th centile, large for gestational age. So with this, we have completed around 7 topics three short notes and four short notes and three long answers. So hope you have enjoyed the session. Tomorrow we will meet at the same time between 6 p.m. to 8 p.m. with another set of neonatal questions. Okay, bye bye. See you. Meet you tomorrow exactly by 6 p.m. Bye bye.